She's going to talk to us today about understanding trauma and informed care. Please give it over to Tracy White.
This is not mine. This is out of the water thing. Although I'm not needing wine today, if anybody wants it. No, it looks like wine. It is not wine. Yeah. So let me just make sure. Okay, so I think in the 27 years I have been doing presentations, I'm more nervous today than I have ever been in my life, because this is a topic that is very near and dear to my heart. It's something that I've personally gone through and am going through and will continue to go through. So if I can talk to any of you, especially, I'm so glad there's so many students here, because this is something I've kind of made my mission, is to try to get all of us a little bit more aware of trauma-informed care. Does anyone know what trauma-informed care is? Exactly my point. It's becoming a buzzword a little bit again. I've seen a couple of topics on it in the last year, and a friend of mine presented on this at ASRT in October, and as I was sitting in her lecture, I'm going, that's what's been missing in my experience, and I'm going to tell you about my experience today. So if I sound nervous or if I get a little emotional, I'm sorry. That's not typically my presentation style, but this is just something that's very personal to me, and I'll tell you why. Trauma-informed care is talking about dealing with people that have been through a traumatic event in their life. Okay? It's something that we as healthcare professionals need to get more on board with. Those patients that come into your clinic that may be, I can't cuss in here, but a butthole, because they're not very cooperative or hard to get along with, or they lose their temper, or something like that is going on. Now, one, they may just be a butthole, okay? Two, they could have been through a traumatic experience in their lives. That does change their emotional, psychological, and physiological reactions. I think before this actually happened to my family, I was probably one that would be like, oh my gosh, I'm never going to get through this patient. They are the rudest patient I've ever seen in my entire life. When you look at it from a different perspective of maybe they've been through a traumatic event in their life, I hope it gives you a little more understanding after today. I'm not saying excuse their behavior. There is not an excuse for behavior or treating anyone badly ever. But there may be a reason that they have the physiological or emotional response that they do. And so I just want you to keep that in the back of your mind moving forward, that maybe this person's been through something. This is really, trauma-informed care actually started in the 70s after the Vietnam War, The soldiers came back from Vietnam with PTSD. We didn't know that's what it was called back then. Nobody had a name for PTSD back then, but the soldiers came back traumatized. And dealing with that in the world in which, for one, we weren't really for the Vietnam War, and so soldiers were not welcomed very warmly. So dealing with all of that, people started to understand mental health a little more. And that's really what we're talking about today. I think the statistics will be alarming for you to understand how many people have been through a traumatic event that has left them with some of these responses we're going to talk about. So I think that's really just my goal today, is to help you understand what trauma-informed care is. I'm not a trauma-informed care trainer. I'm not a psychologist or a psychiatrist. I'm a mom, and I'm not an expert on mental health. But I do know what I've been through, and I do know a little bit about dealing with that. This is my Colby van. He is my heart and my soul. He is my 30-year-old son, and this was his vehicle on December 11, 2015. At 6 o'clock in the morning, with a 7-inch visibility in fog, this is what happened. He collided with the diesel tanker. I'm sorry, I get a little emotional. I'm trying to pull it in. It's been 7 years almost, but it's still very hard because from that moment on, my life has changed. And so has his. His life changed in an instant. From going to a job that he had a degree in to moving back home with his mom and dad for a little while. Because he had a traumatic brain injury. I gotta breathe. Sorry, y'all. I didn't want for this to be heavy. This was supposed to be informative. And let me just say, he's good today, okay? This is a picture that was about 6 months ago, so I want you to see him today. And I wanted you to see that looking at him today, you would not know that he has a traumatic brain injury that affects his daily life. Okay, so there is a silver lining in these people. But he also doesn't look like someone you would expect to come in your clinic, and if you're an hour behind, or if there's loud noises in the waiting room, kids screaming, people on their speakerphones, will have to go outside and pace without losing his temper, because that's a trigger for him. And so I just want you to put this face on your patients when you see those patients that come in that maybe you don't understand why they're impatient, or why they keep asking you how long before their time, or why they keep going outside and inside. There's different triggers for different people. And for him, those are some of his triggers. We've sat in many doctor's offices over the past 6.5 years. People on their speakerphones, kids screaming, running around, people talking to him, asking him questions, the lady at the reception desk wanting to fill out 30 more papers, and then getting them in the exam room and waiting for another hour, and just saying, calm down, it's okay, or get over it. It doesn't work. It's not a mental thing they can get over. It's an emotional response that their body interacts with. It's a fight or flight moment. Have you ever had a fight or flight moment when your adrenaline gets big? That's what they go through every day. And these little stressors hit them. And you can't tell somebody to just, breathe or calm down. So you have to think about that as we go along. Okay, we'll get it together now. Okay, he can't even look at that previous picture. He's seen that picture of his vehicle one time. He does not even want to think about it or talk about it or look at it. So that's okay. So it just triggered him. I have triggers too. We'll talk about that. Okay, so our objectives today, and Kendall, I have no idea what time I started, so keep me on line. Okay. All right, so we're going to talk about understanding the different types of trauma and how prevalent it is, which is very prevalent. We're going to talk about the signs of trauma, and this is not trauma like ER trauma. You get it, right? It's a traumatic event. It can be a long-term event, but it's a traumatic event. Understanding trauma's effect on behavior, not excusing it. That's where a lot of people get confused. It's not excusing it, it's understanding it. And having a plan in place of how to not let it get to a higher place. How do triggers affect their behavior? So we'll talk about that. Interventions to prevent that. And then ways to assess your patient to determine a de-escalation plan. Now, if you are is anyone part of the trauma-informed care program at your facility? Does anybody's facility have a trauma-informed care in process? There is a whole training that goes into trauma-informed care. Obviously, because you're talking about mental health and things like that, it has to be, there's modules that are followed and training that has to occur for that to happen. But it's a process of, we're going to talk about this process a little bit, but it is, trauma-informed care is not only something I just want to educate you on that exists, but you may go to places that actually have a trauma-informed care program in place. And my goal is for everyone to have that in place. Do you know teachers have already adopted this? Teachers are going through a really difficult time, especially in elementary schools, with children that have been through traumatic events. So it's not just healthcare. Children are have a big growing issue with mental health. COVID, we'll talk about that. But teachers have already kind of implemented this. So they have a really bad kid that's behaving badly. They started saying, you're not that you're a bad kid, but what has happened to you? What have you been through? And trying to understand that. So it's surprising that no one here has a trauma-informed facility. So I didn't know of any locally, but as I started looking into this more nationally, they're trying to get it implemented. Now remember, trauma-informed care, the phrase started in the 1970s. 50 years, we're still not implementing something that we know is needed, and I don't think we're going to be able to avoid it much longer. Got to do a couple definitions. I'm sorry, this coloring didn't work really well here, did it, with so many lots. Trauma is an event or series of events, an experience or a prolonged experience, or a threat or perceived threat to a person's well-being. Key word in this is perceived, okay? Perception is a big part of traumatic events or mental health. Just because you think they're safe or they are safe, if they perceive that they are not safe, then they're not safe. Because their body is telling them they are not safe. If they have a trigger, and even though you know it's a safe environment, if they perceive it as a threat, it is a threat. Their daily coping mechanisms can be things like, they can have behavioral responses such as filtering through that experience, everything that happens to goes through that traumatic experience. So think of children on a daily basis. Think of our patients too, but think about children and the things they've been through, and then every day they have to filter through their own experiences that day. They live in a lot of fear and a lot of triggers, and our patients will have that too. So different types of trauma, and again, this is not really that important because a lot of these traumas cross over to different types, but by definition they do call type 1 or acute trauma exposure to a single overwhelming event. Death of a loved one, a sexual assault, a natural disaster, something of that. These people will be hypervigilant, exaggerated responses, overreact, misperceptions, and detailed memories. So that will be a little different from our complex or our type 2, which is an extended exposure to a traumatic situation. These could be bullying, children that go through bullying. Doesn't have to be children that go through bullying, that could be anyone. Home removals, children that are removed out of homes, put in foster care, back into home, foster care, back into home, or profound neglect. Disassociation, rage, social withdrawal, denial, psychological numbness, or sense of a short future. Anybody come to mind in any of these so far? Do you know anybody with some of these? Or seen a child recently with some of these? And a lot of our patients will have some of these. Now, it's hard to pinpoint that. You may only have 10 minutes with that patient, and you think they're just a butthole, okay? And they may be. Remember, that's one answer, or the other answer could be they've been through a traumatic event in their life. There's also crossover trauma, and this is something that has long enough effects to carry over. Something like a mass casualty school shooting, refugees that are dislocated, car accidents with a traumatic brain injury or serious injury, or fatalities involved. These people can have depression, chronic pain, sleep disturbances, concentration problems, and irritability. This is where Mike Colby falls in. Okay? He had a car accident, he had a traumatic brain injury, he walked away with one tiny scratch above his left eye and a dislocated left hip, no other signs of anything. So in the beginning we thought, hallelujah, we're so blessed, and we still are. But the long-term effects of a traumatic brain injury on the temporal lobe means he has mood disorders, and I'm getting a restart notification. He has mood disorders, and he has had bouts of depression. It took us 5.5 years to get a good diagnosis and a physician, a psychiatrist, who knew exactly what he needed. For the first 6 years, all they did was give him antidepressants, and that was not what he needed. So it's a long process, and if you told me on that December 11th phone that it was going to take us 6 years to get him the help that he needed, I would have probably just buried my hand in the sand and not got out of bed or something, because it's been a long, long process, and we still have things we deal with every day. And these are some of them: depression at times, sleep disturbances, a lot of concentration problems. He can be very irritable. But when he's not, if he walks into this room right now, you would not have any idea he had a traumatic event in his life. He would be polite and yes ma'am, and yes sir, and smile, and be perfectly fine until you gave him many tasks to complete. If he knew there was something coming up that he had to do, anticipating having to do something, or if there was too much noise or too many people around him, that would be a trigger for him, and he would probably just leave the room. So he does that quite often at family events, and it's taken my family 6 years to realize he does like them, he just can't be around them all very long. So they take it personal sometimes. They're like, no, that's him. On Christmas Day, he's in, he's out, he's in, he's out, he's in, he's out. And he has to do that to keep a smile on his face. If I required him to sit in there all day and visit with everyone, it would not be pleasant. There's also such thing as secondary trauma, and this could be being a witness to a traumatic event or dealing with someone with a traumatic event. This kind of relates to me. So a child in a serious accident, watching someone die. So after a few years of dealing with this, because I didn't know anything about mental health, didn't know anything about mood disorders, didn't really know anything about depression. I never have had to deal with any of that personally. And when this happened, I sought some help, really just trying to figure out how to deal with him. But in the process of trying to deal with that, here I'm finding out that I have secondary trauma, probably a touch of PTSD, and I'm like, oh my gosh, you're right, I probably do. I probably have a little bit of that, and I do have some triggers. And so it's normal. Most of us do have some sort of, carry some sort of traumatic event or exposure to a traumatic event with us. And so if you do, and if you've had that in your life, if you haven't pinpointed that and know why you do some of the things you do, maybe today you'll understand maybe that's because of something that happened a long time ago. And if that's the case, there is help and there are people. You don't have to live that way. Kobe's quality of life has gone up so much since we found somebody that knew the right medications he needed, how he needed it. And it's not an antidepressant. That's not what he needed. He needed a mood stabilizer. So it's taken a long time to get him back to where he should have been. So it can happen. I just meditate. I don't know. Sometimes I just scream really loud too, but most of the time I'm pretty good. So what is the actual definition then of trauma-informed care? Intentional thinking and intervention. So think about that first word, intentional. This is something you have to keep on the forefront of your mind when you're dealing with people that could be difficult, that means they could have been in a traumatic event in their life. So intentionally trying to intervene. These are directed through understanding their profound neurological, biological, psychological, and social effects that could have had on them. So we always tend to think that this is mental health is a mind thing, and it is, but it can provoke these physiological changes in us. When they get that fight or flight, it really is that adrenaline, that fight or flight. They become very defensive, very angry, very guarded, and it takes a minute to get out of that. So what we call it in our house is spiraling. He's spiraling, here we go. That means stop. That means stop the situation, find a de-escalation, okay? So in healthcare, it's kind of the same thing. If you're in a trauma-informed care program at your work, they will establish some of these procedures where you assess people, determine if there may be an issue, and then if you see some triggers affecting that person, then you start a de-escalation plan. Because it does no good to argue with someone in a spiraling condition. If you've never dealt with someone with mental health issues, do not ever argue with them in a spiral. It will not be effective, and it will leave everyone exhausted. I have been through many of those. So we need to recognize that they need safety, connections, and ways to manage those emotions and impulses. For a long time, I would get really mad at him, and I'd be like, you just need to stop and just take a breath. Well, in the moment, his brain doesn't think stop and take a breath. It took me 5 to 6 years to understand telling him all these things did no good. You can't tell someone to make their physiological body stop and take a breath. It's something that physiological happens to them, especially if it's a trigger and something that's gotten them to this point. You just kind of have to let that moment pass and not keep escalating. So triggers. Triggers are something really important. So we're going to talk in a few minutes about how to implement, what are some easy things to do to implement trauma-informed care. And if you know some of the things that cause this, then these are things you avoid, right? These are signals that make the brain know there's a danger. And that's where that fight or flight comes in. So anything that person perceives as a danger, and again, we're talking about perception. Doesn't have to be a real threat. A patient might think you're a threat to them. You're not. But if they perceive that, then it's real in their mind. So that mind-body connection goes into fight or flight or freeze. And then that triggered individual may experience fear, panic, anger, and agitation. Something all of us don't want our patients to get to that point, right? We don't want anyone we have to be around to get to that point that they're fearful, panicking, and agitated. So you're going to either have emotional or behavioral responses or some physical responses. These patients will. Denial, confusion, anger, guilt, anxiety, guilt. Let me talk about guilt a second. These patients that have these traumatic events and then have an episode in which they do lose their temper or they do have a spiraling event, after that's over, or as far as my experience with my son, when that's over, they didn't go through a guilty phase. Because then rationale comes back and they understand that they showed out, they were rude, they were ugly, they're embarrassed, and then they go through guilt. And for COVID, guilt would last sometimes 2 or 3 days. And it would sometimes be worse than the first response, whatever that was. And they ranged from blackouts to punching a hole in the wall to contemplating suicide. So they were a range of emotions. And so after that was always a period of, I'm just a bad person. I'm so sorry. He's told me more times than one he wished he'd just died. I should have just died in that car accident. Because he was so embarrassed by his behavior. Because that was not his normal behavior. And so you have to understand guilt can come with a lot of this. And it was always hard for me to forgive it immediately because, oh golly, it made me mad. I'm like, can't you just, stop? And it took me years to realize, no, you can't. And so you have to forgive it. It was not intentional, and move on. Not excuse it, but you have to forgive it because they just go through a harder experience in the guilt part. Flashbacks, withdrawal, difficulty concentrating. That's probably Chloe's biggest problem is concentration. He had a frontal lobe injury as well. He does really good with 1 or 2 tasks, and he's getting really better at that with his medication. But we always laugh because we'll go to do something and be like, what did I just go to do? And so now I stop him on it. We're like, what were you doing? He's getting lazy. He thinks about it, he can remember it. But their body will get insomnia, fatigue, muscle tension, headaches, chest pain. Why do they have those physical responses? Any idea? After a fight or flight. What happens to your body in fight or flight? All that adrenaline. So what happens after all that eases off? You're exhausted. Your body has just been through a marathon. And so a lot of times they get this whole, exhausted, fatigue, sleep, unexplained pain. So let's talk a little bit about depression because I think it's a word that we use way too much, too broadly, and there's lots of things that go into depression itself. I had no idea how much time I had. I think I'm doing okay.
30 minutes, you're doing great.
Oh, okay, good. So depression is a bigger category. If you look on the second point, it says the umbrella of depression encompasses major depressive disorder, related mood disorders, including bipolar disorders, postpartum depression, PTSD, anxiety, and suicide. So all of those are included under a depression umbrella. Depression basically is melancholy, loss of pleasure, loss of energy, difficulty concentrating, and suicidal thoughts. Broad term on depression, okay? So when you talk about that, someone may not be diagnosed with depression, but they have a mood disorder or PTSD. Just know those kind of go hand in hand, but that doesn't mean they'll be treated with antidepressants or something like that. My Chloe actually has a mood disorder. It's a bipolar 1, which is no highs when he doesn't get euphoria and then extreme lows. He just has a few low bouts, so that's a bipolar 1. But he's not treated for depression. He's treated for his mood disorder, his temporal lobe. So there is differences in those. Look at some statistics with me. In the U.S. alone, depression affects 18 million adults, or 1 in 10. It's the leading cause of disability for 15 to 44. 44 is not very old. And for disability to be affecting people from 15 to 44, depression being the leading cause, that's alarming. We're going to need a lot of mental health knowledge over the next few years from now on, honestly. It's the primary reason someone does a suicide every 12 minutes. 41,000 people a year commit suicide. And homicide only claims 16,000 a year. And then 490 million disability days from work. That adds up to $23 billion in lost wages and an economic toll of $100 billion a year. We're going to talk a little bit later about staff and mental health, because it's something that even though we're dealing with mental health sometimes, we've got to take care of our staff that are dealing with mental health. And so things like mental health days, I've taken some of those over the last few years where Cheryl, sometimes I'm like, mental health day, come on. And I'm serious, it's a mental health day. Okay, so 70% of adults in the U.S. have experienced some type of traumatic event. Think about that, 70%. That's 70% of us in this room have been through a traumatic event at least once in our life. Do you agree with that? Just trying to see if people are like shocked at that, or because a lot of us have been through that, so I'm just curious if everybody recognizes that 70% of us have been through that.
Didn't all of us just go through a traumatic event?
COVID-18 was a traumatic event, yes. And I've got some numbers at the end on teenagers and COVID, some new data on that. It's going to be alarming. PTSD, which I have a problem with that term. I think it's thrown around too much, but it is a true thing. PTSD is post-traumatic stress disorder. So if you've been through a traumatic event, the way you handle stress is a disorder. You have a disorder of handling that stress. So it's kind of just all-encompassing of what we're talking about today. A couple of things with PTSD. I think a lot of people have it. They don't know they have it. I've had it. I have it. But a lot of people think only people in uniform have it. That's not true. If 70% of us have been through a traumatic event, that's, more of us probably have PTSD than we know. But people also just use it if they're stressed and they're like anxious. Like, I think I have PTSD. No, there's guidelines that go with PTSD. So COVID and mental health, we're going to talk a little bit more about that at the end, because when I did this presentation, I just talked about we're going to have to deal with that, but I did get some new data last week from a report from the CDC, and I'm going to end with that, so we'll talk about that. All right, so here's the process. If you are, I know you can't implement you can't implement the program yourself, but if you were to do that, or just think about that, even in your department, you wouldn't have to have a formal program for this, but you could have things like this simple assessment that they urge you to do on every single patient, okay? This survey never mentions mental health or a traumatic event, okay? It's not going to say, have you ever had a traumatic event in your life? No. Do you have mental illness? You're not going to ask those questions. But there are some questions that you can ask, and we'll talk about those in just a second. It should be done on every patient, though. If you only pull out the patients you think might have been through that, you're going to have a wrong distribution. That's not going to be accurate. Because if you looked at Mike Colby, you wouldn't think he had a mental health issue. So you would ask it to everyone. It would allow you to know a better understanding of any potential traumas, target some interventions with them, understand maybe what their triggers are, and then how you can take that information, and if you see that happening, form a de-escalation plan, which means let's not take it any further, let's bring it back down. And then taking that survey would need to be somebody that was trained though in trauma-informed care. You don't want just somebody asking questions about mental health or traumatic events that's not trained in the delicacy of that. Because it's a very delicate issue. You don't want to be asking people questions related to sexual assault or something like that without somebody that has a little bit of training in that. And then if it's not done correctly, it can be more damaging. So maybe you just triggered something they completely didn't even know was a traumatic event, and that's not what we want to happen. So we want someone with training to do that. So the first section would ask things like, select the things that have worked to make you feel better when you're having a hard time. Does listening to music help you? Watching TV, walking the halls, getting a hug, that would be my last one. I'm in a traumatic event, I don't want a hug. I'm a huggy person, but I don't want a hug if I'm having a moment. Wrapping up in a blanket, using a weighted vest, voluntary timeout or flight. So I can tell you if Kobe Watts doctors would have this form everywhere we've gone the past 6.5 years, it would have been so helpful. Because we could have put on there, we want a quiet room. COVID was really good because what did you do during COVID if you went to the doctor? Sit in your car. You didn't have to be around anybody, did you? So we sat in our car, and when they were ready, they called us, and we didn't have to worry about any of that. It was really good for my family. He now uses telemedicine, which is good for him because he doesn't have to deal with that. So he doesn't want a hug, and he doesn't want to wrap up in a blanket. Somebody else, that might be comforting for. So So if you just ask this first without the words mental health or anything to do with a traumatic event, I would just be like, oh, that's kind of weird. Okay, well, maybe I like to watch TV. But I wouldn't be offended if someone had asked me this. The second part can say, is there someone there who helps you or is helpful when you've been upset? So if you ask someone that, what else did COVID do as far as visitors? You couldn't have a visitor, could you? You couldn't have anyone go in the room with you. That was really hard for us because I was the one that usually explained things in a really nice way without using the words mental health or traumatic event, because that's not stuff he wanted to hear. He still would not tell you any of that. He would die if he knew I was talking to you today. But this is a safe environment, and so I feel it's my job to share this information. I've wanted to share it for a long time, but wasn't in a place where I could do it, because until he got in a good place, I couldn't do that. So maybe he needed me there, or maybe he needs his girlfriend there. That would be good to know for someone if they start having a trigger and something happening. Maybe you get that person. That's their person that's calming to them. And then maybe ask them, what are some things that make it more difficult when you're already upset? Those are triggers, right? Things like being touched or being isolated, having doors open, loud noises, yelling, specific scents or smells, no control, waiting. So on that, we could have selected doors open, loud noises, yelling, waiting. Okay? And that would tell them, make sure we have a quieter environment. Fourth part can say, have you ever been restrained? Now, if you haven't had that event and you're looking at this on your form when you're checking in the doctor's office, you might be like, have I ever been restrained? Okay, but it wouldn't offend me, so I could just put no. But if someone has, what knowledge is that for you as a healthcare provider or a teacher? I mean, that's great information that potential could happen. And then the last section can say, what can we do basically to make you feel safe here? You know, those are four simple questions that can be asked along with how many questions do you have to answer when you go to the doctor already? 5 billion. So what would 3 or 4 more questions hurt on an evaluation form anywhere to make sure that that could happen? Again, you would have to do it for everyone. You don't want to single people out. And you never use the words trauma or mental health. And then there could be more questions. And in a formal trauma-informed care program, there's modules and books, and it's not a 50-minute lecture, okay? It's a lot that has to go into that. But these are simple things that we can think about. Even if you can't do that where you work, which I know you can't implement that, but you can try to remember in the back of your mind that maybe they're going through something like this. And instead of just calling them, you know, a butthole, maybe we try to understand maybe a little bit about what they're going through. This is from a patient that says, a non-trauma-informed system punishes and blames your adult actions and asks, what is wrong with you? A trauma-informed provider will hold you accountable for your actions, but give you space and time to process what happened to you without adding more guilt and more trauma. That's a big statement for me, because we have been through that. And I've had nurses roll their eyes because he was huffy and tired of waiting and, you know, and then be short with us because he's never been what I would call extremely rude, but he's been very short and huffing and puffing with people before. I wouldn't allow him to be very ugly. I'd still smack him across the face, but he's still my kid. You know, he's 6'2" and 30 years old, but I'm still mom. So, intervention and prevention. You want to make sure there's an intervention there so that you don't get to a point that you have to de-escalate it, right? So understanding is the number one part of that. And then the core principles that go with trauma-informed care, just quickly, are patient empowerment, choice, collaboration, safety, and trustworthiness. So for empowerment, by providing trauma-informed care, you give that individual who's been through a traumatic event, you empower them as a survivor rather than a victim. They get a little bit of choice in it, and they get a little bit of empowerment by helping make those decisions. Gives them a little bit of normalcy in spite of what's actually happened to them. Choices are important because you don't want to make choices for someone. You want them to feel like they have control. In radiation oncology, I talk to students a lot about our radiation oncology patients a lot of times need control. And sometimes that control is like, well, my appointment's at 2, I'm coming at 3. Because that's their control. I can't control anything else, but by golly, I'll control what time I get here. I'll be late, I'll show you. So sometimes for even patients who have been through a traumatic event, they need a little bit of control in their choices. And so we should do that with everyone. Just because they have a mental health issue doesn't mean they have the capacity to understand. They don't. Cognition is perfectly fine. It's the way they handle some things. And then collaborate. Let their family be a part of this. They don't need to be isolated. They need to collaborate with others to come up with a plan for treatment. Now, all of this is HIPAA compliant, obviously, right? If you're talking to other family members or girlfriends, things like that, it still has to make sure that that patient is okay with that. Safety, I think this is the number one thing we're going for because these patients often, and you know, and I won't even tell you that Colby ever felt unsafe anywhere. It was just that ability or that filtering his experiences through the lens of his, whether or not he believed it and whether or not I believed it, hospitals and healthcare settings still trigger something in both of us. I was really having a conversation with God 2 days ago because I've been now having to take care of both my parents. My mother had pneumonia a few weeks ago. My dad had open heart surgery in November. Spent 3 weeks in the hospital. My mom got sick. She's had pneumonia. My dad had another heart cath this week because one of his newborns. And I'm sitting in the hospital and I'm like, God, we had this conversation when Colby was in the hospital for 2 weeks. That would you please never put me in hospital situations again? I hate hospitals. I hate to be in them. I hate to go to healthcare settings. And I'm sitting there for, 72 hours. And I'm like, God, we've got to talk about this. My sister's either got to move home so she can do the hospital part, or maybe you're testing me, I don't know. But I don't like to be in those settings. And I think for him, he has that too. He doesn't know he has that, but those places trigger him. It's just, you can feel him walk in and it's just a suffocation. And I get it too, so I get it. And no offense to St. Bernard's, because that's where he was, I don't go there. I love St. Bernard's, I work there, but I don't go there. I don't like to go there. It reminds me of ICU and 2 weeks of the hardest time of my life. So I don't go in that place if I don't have to go there. So safety is what everybody is looking for that's had this experience. And trustworthiness. Here's another thing. Don't tell him it's going to be 10 minutes and it'll be an hour. Okay? Because you've just broken trust and he's not going to believe anything else you say, and the worst thing he has to do is wait. So if you're going to be behind, tell him. Okay, we know your appointment was at 10, but we're really behind and it may be right 10:30. If you'll tell him, it's fine. If you don't tell him and stick him somewhere, then it's going to just continue to escalate a little bit. So making sure that you give clear expectations about what's going to happen, the time frame, who's going to do it. We have to be really careful for people with that sexual assault and make sure the gender, asking is there a gender that is specific for you when you are feeling unsafe, because that's important. And again, remember, this is all about perception, not reality, but their perception of the circumstance. And again, that's kind of what this talks about. Welcome them, make them feel supported, ensuring that they maintain healthy interpersonal boundaries, keep consistent schedules, give them notice when things are going to change, maintain communication, and then make note of an assessment or a de-escalation form. Another thing that bothers Colby, so I have to call every doctor he goes to before he goes now because I don't go with him all the time anymore. So I have to call every doctor's office like that mother of a 30-year-old, and I know they think, why is this mother calling us? Because they have no idea what we've been through. And I have to tell them, don't talk to him about billing. Bill his insurance and then send it to my address. I pay his bills still, and so he gives me money, I pay his bills, but if you stop coming to the window and say, that'll be $432 today. He has $432, but he didn't expect to have to pay $432. So those are little things people don't understand. So I'm always up on the receptionist. Please don't turn on his videos, send it to me, or here's my card on file, and he'll pay me. Sounds stupid, right? It's a little thing that saves us a lot of stress in our household. And you have to find those things that take away a lot of stress. Okay, so involving them in their process. process, screening them for trauma, and then training your staff. How much time do I have?
You have 13 minutes.
Okay. Adverse or difficult life experiences affect all of us in ways and are more about neurophysiology and less about character. Despite the common belief that what doesn't kill you makes you stronger, evidence from neurobiology and public health says that changes in the brain and body that occur outside of awareness are not subject to being overridden by grit or toughness. Suck it up, buttercup. Who used to say that? Those of you that from ASU. Lynn Hubbard used to say, suck it up, buttercup. Sometimes they can't suck it up. Sometimes that's just not, and it's not good to tell them that. It makes them more angry to tell them that. Telling someone who is clinically depressed to get over it or to make a choice to be happy is not appropriate. I've been guilty of that. Just get over it. Choose to be happy. Make it a good day. Choose a good day today. It's not their real. It's not something they choose. I've had Chloe tell me before, do you think I would choose this? Why would I want to feel this way? It's not a choice. It comes by honestly. So staff, let's not forget our staff, because working with patients who experience trauma is going to put a lot of risk on you having a secondary trauma experience. Make sure that you provide training in this. Educate your staff on they may be getting some crossover trauma or secondary trauma from dealing with people a lot, especially if you're in that environment where you're dealing with a lot. Think about teachers now. Would you want to be a teacher of elementary kids right now? I mean, they go through so much, and COVID has affected them so much. I mean, this is a daily thing. They're having to deal with traumatic experiences. And so they need to be taken care of as well. The faculty, the staff, the healthcare providers, whoever it is. Provide those mental health days. Sometimes you just need a day. Go sit outside in the sunshine and, have a brownie. I don't know. Do something that out of your realm of daily activities. Yoga, meditation, and supporting mental health. I know a lot of insurance and facilities now offer incentives for for employees to, use their gym memberships, yoga, encourage that because it makes us, better employees. Awareness, and that's why I'm talking to you today, as hard as it is to talk about something personal. I just want to bring awareness to it and help you to understand that not every patient that walks in your facility is okay. Not every student that walks into your classroom is okay. A lot of us that are teaching are not okay some days. It's okay to not be okay. But recognizing it and having a little sympathy towards one another will go a very, very long way. And it's going to require a paradigm shift. It's not the way we think. It's not in our mindset to think about other people's mental health and what they may have been through, and to understand that it actually is a physiological response that comes from this. It's not just a mental response that they can control. All right, so this is some new data from the CDC that was on Good Morning America. I was getting ready the other day listening to Good Morning America. They started talking about this, and so I didn't get it all. I had to go back and read the article, and I made a lot of notes on it. But I'm going to add that to my presentation because it's alarming to me. So the new data shows that a third of high school students reported poor mental health during the pandemic. Poor. There's excellent, good, fair, poor. That's like the last one. And a third, 33%, said they had poor mental health during the pandemic. 44% reported feeling persistently sad or hopeless. Hopeless is a big word. Hopeless is serious, and that's almost half of high school students that felt that way this year. That's very significant. 55%, this is even more alarming, 55% reported emotional abuse by a parent or other adult in the home, and 25% reported a parent losing a job. Over half teenagers had emotional abuse in the home while during the pandemic. Think of that. So if that's teenagers, what do you think that number is for elementary age kids that were running around screaming? I'm glad I wasn't home with them. I'm glad my kids are grown. That's a hard thing for parents every day. They're still trying to work. No excuse for it, but the parents themselves probably had some mental health issues, and so dealing with this is hard too. That's alarming, people. 55% emotional abuse. So the CDC director says COVID-19 has created traumatic stressors that have the potential to further erode students' mental well-being. That's further erode. Their mental health well-being was already declining prior to COVID. Blame it on social media, blame it on a lot. I'm glad I didn't have social media growing up. I would have been in trouble. It's got to have a huge effect on students. Psychiatrists and pediatricians have declared a national emergency for young mental health. 50% increase in suspected suicide attempts by emergency room department visits among girls 12 to 17. It was already a high number for girls in that age range, and now we've increased it by 50%. That's ER visits of someone that actually attempted suicide. And all of this is in addition to the already alarming number of amount of mental health crisis growing. Trauma-informed care is going to be crucial moving forward in healthcare, really in life. This is not just for healthcare, this is life lessons. This is encountering someone in Walmart, this is encountering someone in a grocery store. Just being a little kinder maybe will get us a long way rather than judging somebody immediately on their behavior. Not excusing it, understanding it, there's a difference, and trying to just be a little kinder really makes a huge difference. I want to end again with my picture of Colby because I want you to keep them in your mind. When you have that patient that's horrible, I want you to think about how, maybe there's something else going on there. And again, to remind you that mental health doesn't look like a specific thing that you think. I think he's pretty handsome. He's the cutest, sweetest, kindest-hearted young man in the entire world. And what has happened to him is not his fault. And it's something that he has to live with. He has to work every day to get through that day sometimes. But he's doing great. And I love to see him smile. But I want you to remember, that not everyone looks like they have mental health issues. These are my sources. Does anyone have questions? Yes.
Comment. This has been very eye-opening for me. I want to talk to you afterwards. But do you think it's fair to say that the healthcare industry does not address mental health as heavily as they do everything else, and that's a big problem?
Yeah, when we started this journey
You
almost
have to understand.
6.5 years ago, I was so frustrated because I've been in healthcare my whole life, and when we left the ICU 2 weeks later, the neurosurgeon came up to me in the hallway, and we were so elated that cognition, he had finally woke up, cognition was fine, no memory losses, everything was fine. And I remember being so excited, and I remember the neurosurgeon saying, "Good luck."
Yeah, that's it. That's what you
And I'm thinking, good luck? What? I don't know what that means. It wasn't long after that we did understand what it meant, but nobody prepared us for that. Nobody prepared us for what happens long-term after a traumatic event or a traumatic brain injury. And that was all on me. And I drug that poor child to 20 doctors. And they all were like, let's try another antidepressant. Let's add this to his antidepressant. And I'm like, there's got to be something. And it was hard because I am physically dragging him because at the time he was 24. Do you think he wanted to be going to the doctor with his mom and talking about mental health and brain injury? No. So I drug him everywhere until we finally got to a psychiatrist, which he didn't want to go to. And in the building, he's like, no, I'm not going to a psychiatrist. And I'm like, if you had a lung problem, I'd take you to a pulmonary doctor. If you had a heart problem, I'd take you to a cardiologist. You have a brain problem, we've got to go to a psychiatrist. And the minute we walked in, it was he told us everything that we knew, the symptoms he had. Yep, this is the problem, this is how we fix it. And our lives changed from there. But if I hadn't known a little bit and been persistent, nobody else would have helped us in healthcare. They don't want to address it as an issue. Nobody wants to talk about it. And it's going to be a huge, huge problem if we don't learn how to address it and how to deal with it. People themselves don't even know they have a mental issue. They don't know they have mental health issues. Yes?
Have you found any programs specific for radiation oncology in the sector that could be starting?
No. And the BA, okay. When I went to the talk in October to ASTRO, all she was talking about was how to implement in this programs. And I thought, well, at least we're starting to implement it in curriculum. At least we'll get it to these guys if we don't get it to our already, I'm not really in a position I can go to hospitals and say, you need to implement this. I'm a faculty member at the university. You need to implement this. But I do think we need to start the conversation, and at least maybe these guys coming into healthcare will understand it and have heard the term. When I asked any of you if you've heard the term, no one raised their hand. So,
It makes perfect sense. I mean, it's really good.
a lot of people don't want to say that the person acting like that has a valid reason. They're just a bad person. And I probably would have been guilty of that 7 years ago. So I've lived it, and I just want to make sure everybody else can understand it. That's all. If you Google trauma-informed care, you'll get tons of things, and modules and training booklets, and it's lengthy. It's like implementing any other type of big, program. Yeah. That's a traumatic event. Yeah. Come into a women's center where everything's pink, and you're a man. Yeah. Yeah. Google it, there's lots of stuff on it, and, our goal would be for it to spread, at least awareness. Thank y'all.